Good morning to all speakers and attendees. We continue today with the IWBNC. After a successful day with more than 3,000 registers from over 120 countries, we start today with an outstanding schedule which we hope you enjoy. Welcome to the second day at IWBNC, connecting the neurosurgical community around the globe. Thanks to all the audience who follows our broadcast. We are live now on the second day of the 2020 International Web-Based Neurosurgery Congress. So remember, we are streaming on YouTube Live too. Well, we have the honor today of having Dr. Paul Park. Dr. Park is a well-known neurosurgeon from the University of Michigan. He is the director of the Neurosurgery Spine Program and professor of neurological surgery and orthopedic surgery. Now, Dr. Park is going to share his lecture, Current Applications of Robotics in Spine Surgery. Please type your questions in the questions and answers section. We will read them after the end of Dr. Park's intervention. Welcome, Dr. Park, and thank you. It's all yours.
Thank you. I do really appreciate CN for inviting me to participate in this wonderful Congress. This is, I think, very unique, and it may be something that will be very prominent in the future. So here are my disclosures. So robots, I think the question is, what should they do? And when we think about a robot, I think, at least for me, and I think most people, we typically think of a robot as a machine that could perform a task autonomously in a safe, reliable, efficient manner without human error. And it's just a picture, it's a simple picture. I could have put a video in, but this is a robot that is folding an article of clothing, and the robot does the whole task autonomously, so by itself, reliably, consistently, probably very quickly, and without, quote, human error. But is this what a spine robot does? And the answer is no. Currently, spine robots are not autonomous, meaning they don't do the task themselves, but rather they're assistive devices that only impact a portion of the procedure. So, the fact that it doesn't do the task by itself, people have termed this more of a cobot, meaning it's like a airline co-pilot where it is assistive, they help the surgeon, but they do not do the task on their own. And they really only impact one aspect of a spine procedure. And so it's more, robot these days are more of a role player. Now, I think that'll change, but that's a current state of robotics in spine surgery. And so specifically, what do spinal robots do? Well, they're really optimized for pedicle screw placement, and really percutaneous or minimally invasive screw placement is what they're designed for the most part. The robots can do cortical screw trajectories. It can also be used in open traditional spine operations with placement of pedicle screws, but it's a little bit more of a challenge in that circumstance, because when one does a screw planning, which is a part of the workflow of a robot, we often plan screws that are fairly medialized because it's optimal, but it's a challenge to obtain that trajectory with a midline approach because we need very wide exposure. So, a certain degree of planning needs to be performed when using a robot with a traditional approach, although it's definitely very feasible. Some of the more current, newer generation robots are navigation capable. And I think this is a bit of a prelude to the future iteration of robotics in the near term, in the aspect of how robots can produce more value. Because one can argue if all robot does is assist a surgeon in one aspect of a procedure, the screw placement, it may not produce as much value as would be warranted by the cost. But if a robot were able to impact every aspect of the procedure, and add reliability, consistency, and hopefully better outcomes, then a value argument can easily be made. And so I think future iterations in the near term of the robot will expand upon the navigation capability to make it more seamless in terms of its impact in other areas or every area of surgery. And I'm going to use a couple of examples with that in terms of the T-lift and the lateral lumbar antibody fusion. Currently, the interface is elementary, but that will definitely change in the near term, and I'll go over some of the upcoming advances. Before I proceed with a couple of examples of what we can do with current robotic technology, I think it's always useful to review the literature. And this is not going to be a long review. It just gives an idea of what we know scientifically. So this is what I could find was the most recent review, and it was published in the journal Spine, and just done in 2018. So fairly recent. It included 32 articles, and they evaluated what was considered potential benefits of a spinal robot. One is screw implant accuracy. So that was one endpoint that they looked at. The next was radiation exposure, which is always important because I think it's an under-recognized occupational hazard for spine surgeons, particularly minimally invasive spine surgeons, where the radiation exposure can be quite significant. Operative efficiency and time savings was another endpoint that these authors looked at, as well as length of stay. When really you looked at all the articles, these 32 articles, really the majority focused on screw implant accuracy, and a large number of articles looked at radiation exposure. For the other two endpoints, operative efficiency and time savings and length of stay, there weren't very many articles and not much evidence to support an argument one way or another. So in terms of screw accuracy, 30 of the articles assessed pedicle screw accuracy, 15 using the most common Gertzbein and Robbins criteria. And accuracy was very high. The 75% to 100% was a range. 75% was actually an outlier, and there's specific reasons for this, but I didn't want to go into it so much just because of time constraints. But for the most part, the majority demonstrated greater than 90% accuracy. Radiation exposure, approximately 13 of the 32 studies looked at radiation exposure. And the results, a little bit surprisingly, were mixed. The majority did show a decreased degree of radiation exposure with the use of a spinal robot. However, 3 showed an increase in fluoroscopic time versus freehand pedicle screw placement. And when you really look at the articles, these 3 articles in depth, it was because the surgeons who were involved in the study were uncomfortable with the spinal robot and would utilize fluoroscopy very frequently to confirm accuracy of the robot. I think if they had a bit more faith in a robot and didn't have to confirm accuracy with multiple fluoroscopic imaging, the fluoroscopic time would have been decreased. So I think this was due to the study design more than anything else. You know, when looking overall at the data, the radiation exposure was markedly less with robotic use, particularly with, I think, minimally invasive surgery, where the radiation exposure is much higher typically. So in summary, the advantages of a spinal robot: it's highly accurate, it decreases radiation exposure. I think the predominant amount of literature would support this. And it could potentially decrease operative time. Again, there was not enough studies to actually support this definitively, but I think, in my personal opinion, present generation robots probably don't increase operative efficiency at this point, but future iterations with refinement and improvement in technology, I think that's definitely going to be possible. So when it comes to robotic assisted surgery, and this is an example of MIS TLIF, and this figure was taken from an article published in 2009 with early iterations of the robot. Really, its main role is just one aspect of the procedure, and it's percutaneous screw placement. And really, the initial iterations of the robot, if you look at the diagram, was just a rigid drill guide. And so it would hold the guide in place, and a handheld drill would be manually advanced through the guide, through the pedicle, and a K-wire would be placed. And then the pedicle screw would be placed just typically a freehand, screw placed over the K-wire. So, when you look at the degree of technology, it was not very, very high in that sense. The current generation of robots do more than that, but still, only are involved in pedicle screw placement. And, until we have the robot being able to impact other aspects of the procedure, I think the promise of robotic technology is not quite there yet. I think navigation, and I'm going to go through with that, will allow the robotic platform to be involved in every aspect of the procedure. And I think that in the near term will be the next advance of robotic technology. Because really, when you think about it, the robot really is based on navigation, a navigation platform. And so the robot could be simply seen as a next advance in navigation. And I tend to look at it as a robotic navigation platform more than anything else at this stage. And in future iterations, hopefully down the line, the robot will be able to be more autonomous and can be more helpful, but that's the stage we're at now. So here's an example of what we can do now with robotic technology, and then I'll proceed to explain what will change in the near future with future refinements in the technology. So case example, 63-year-old man, back and leg pain, activity limited, refractory conservative treatment, normal exam. This is something a spine surgeon sees every day. So here's an MRI. So the patient has symptoms of claudication, back pain as well, and high-grade lumbar stenosis at L4-5. This is something I think most spine surgeons see daily. Here are the x-rays. And there's not much of a spondylolisthesis on the MRI, but when the patient stands, definitely develops grade 1 spondylolisthesis that is more pronounced on flexion view, so mobile spondylolisthesis. So one can argue there's multiple ways of treating this. I elected to proceed with an L4-5 minimally invasive laminectomy, and that would be a unilateral approach for bilateral decompression in conjunction with transfemoral lumbar and body fusion. So I've done it in a minimally invasive manner, and I'm going to highlight how the robot could be used here, not just for pedicle screw placement, but for pretty much every aspect of the procedure, the decompression, the discectomy, and cage placement. And right now it's a bit elementary, but future refinements will make this more seamless. And I think this will produce more value for a robotic platform. So here is an example of positioning. This is fairly typical, patient position prone on a Jackson frame. For use of the robot, we have to attach a patient reference array, which is this. This separate array is an ICT because I'm going to use intraoperative image acquisition to acquire the imaging data to be utilized by the robotic system. Now, this is just one method of obtaining the imaging data. A preoperative CT can also be used with fluoroscopic registration. So there's more than one way to be able to use this system. Here's an example now of the patient covered with sterile drapes and the imaging acquisition being performed by our unit here. So this is the cone beam CT, and we'll get 3D imaging spine data that is transferred to the robotic system. And this is the planning station. And this seems like it takes some time, but it's actually fairly quick. Acquiring the data in our institution takes less than 10 minutes or so. And this is transferred to this imaging station where we can plan the screws. And this is our typical planning station. In the upper panel, this gives us a gross overview of spine, and then three-dimensional spinal anatomy is shown here for screw planning. And this is just an example of screw planning of the left L4 pedicle. You can see there are areas that are demarcated for a screw diameter, screw length, a polyaxial screw head. And planning is actually very straightforward. These are all 4 screws planned. And if you look at the upper left panel, you can see how the screws are grossly placed in the spine. And these linear projections posteriorly will allow a surgeon to determine how these line up on the skin, for example, in terms of the skin marking, which would be approximately here. And this is just all 4 screws, just an example of me planning the screw. And it does not take very long. I would say, you can spend as longer or shorter amounts of time, but really 20, 30 seconds is all you need to plan a screw. And here is an example of a screw being placed for this minimally invasive T-lift. And as you'll see, the person on the right is our chief resident who's going to go into vascular neurosurgery. So he doesn't do much spine surgery. And this is his first time putting a robotic screw. And you can see how quickly it goes. This whole video is just over a minute or so. And the screw plans have been made, and the robotic unit is positioning itself. And it does this autonomously. for screw placement, and it's a simple two-step process. It'll take about a minute, and a minute, if everything goes smoothly, is a bit slow. And this is his first time doing it. Okay, so his first time putting a robotic pedicle screw in, so he's going to be a little bit more tentative here. You can look at the screen here, and you can see where the robotic positioning has occurred, and it's lined up with the screw plan. And you can see he's going to advance this drill through the pedicle. And it's going to give a little as it enters a bone, and he stops because he's a little tentative. His first time using it, so he doesn't want to cause a problem. But you can see he's drilled a screw track very quickly. And the next screw is going to be even quicker than what it is here. So it's a two-step process. So the pedicle screw track has been drilled, and now he's going to insert the pedicle screw. And you can see the navigation screen here. The pedicle screw is in view, and you can see it will advance into the particular track that has been created. And it's a simple two-step process here. It's very efficient, and it takes some of the variability out of placing a screw, even with navigation where you have to hold it in stable position. With the robot, you don't actually have to hold the instruments stably. It just does it for you. So you can see a very simple two-step process. So typically in my workflow, the screws are placed first. On the contralateral side, as you can see here, the screw extenders are placed. This is a minimally invasive procedure. On the ipsilateral side, where the tubular retractor is going to be placed, I don't attach the screw extenders or screw head, they're just screw posts. But all the screws are placed, so that's my first step. The next step is placing the tubular retractor. Now, this is done typically under fluoroscopy because it's a minimally invasive approach, but with utilizing a robotic system, I don't have to use any fluoroscopy. In fact, you can see the screw placement, none of us are wearing lead here. And with the tubular retractor placement, typically fluoroscopy is utilized to place a tubular retractor, but utilizing a robotic system, now this is elementary now, you can still place a tubular retractor without fluoroscopy, and you use a robot to do that. And how I do it right now is I develop a screw plan for the tubular retractor. So it's not an actual pedicle screw, but I use a screw as a surrogate. So in this example, the panel, this is a navigation pointer, and this is where I want the tubular retractor to be centered, right over the disc space, correct? So I could do the decompression as well as put the cage. And typically, again, it's done under fluoroscopy, but with robotic planning, this is just an example of a different patient because I didn't have it for the patient that we're doing. I'm planning a tubular retractor plan. You can see it's right here. This is a screw, but it's not really a screw, it's for the tubular retractor. And this is the video showing how this is occurring. So the screw extenders are here. There's no screw extenders here, but the screws have been placed. And now I'm going to place a tubular retractor utilizing the robot. So again, we're not wearing lead at all here. And then through the robotic effector tube, we're going to put the dilators. So we're just inserting dilators according to the trajectory that was planned. And again, this allows us to utilize a robot without fluoroscopy to place a tubular retractor. And this is how it was done here. And you can see here's a pointer confirming that the tubular retractor is in the correct position, and it definitely is in the correct position. And this is the view we get after the tubular retractor is placed and a little bit of the muscles removed. We're perfectly aligned over the disc space without the use of fluoroscopy. And here's a picture of the lamina. This is the right-sided approach here. Here's a facet joint. Here, pars interarticularis is here, so medial is here. And all this is drilled away. Now, this isn't typically done with robotic assistance, but there are navigated drills now that can be utilized. And once a bone is removed, pretty typical here is ligament of flavum here. And I'm going to remove the ligament of flavum, obviously, for decompression, but I want to decompress the contralateral side. And we typically do that by undercutting the contralateral lamina and then removing the ligament of flavum and undercutting the facet joint. But what's always a challenge with the minimally invasive approach, again, this is a small working channel we're using, is whether you adequately decompress the contralateral side. Typically, it's a little hard to tell with the minimally invasive approach, and with experience, it's easier, but it's always a challenge and it's time consuming. But with the navigation capability of the robot, remember, this tubular retractor is placed with the robot, and now I'm able to tell this is a contralateral side. So I've undercut the contralateral lamina, and I just want to make sure the lateral recess is decompressed. And typically, you just have to visualize this, and with experience, you understand you've adequately decompressed it, but utilizing the navigation capability of the robot, now here's a navigation pointer right here. I could tell if I'm adequately decompressed. So this is what it's going to show on the screen. Here's the pointer. I'm on the contralateral side. So I started here with the unilateral approach. I've undercut the lamina, and as you can see here, this is the contralateral side, and I could tell if I'm adequately decompressed because it looks like I'm all the way over. And here's an example on the screen that you see. Here's a navigation pointer, and I'm looking, pointing through the tube. And you can see what we can achieve postoperatively. Here, this is where I was with the decompression, and this is the post-op CT and MRI. And remember, this was high-grade spinal stenosis previously, and with a unilateral approach here, the other lamina is intact. We've just undercut it. We get a great decompression, and with navigation, I'm able to confirm that I have adequate, I've achieved my decompression easier. I don't have to guess at it so much. I know for a fact that I'm well over to the contralateral side. So this is an example of using the navigation capability of the robot in its current iteration. Well, what about discectomy? Again, this navigation is not refined in the robotic platform as of yet, but in the future it will be. But for now, you can put the navigation pointer in a disc space. You can get an idea if you've done an adequate discectomy here. And obviously, if you put the navigation pointer down the tube, this is where the cage is going to be inserted. And you can see this is a midline cage insertion. And this is just the example of putting the cage in. Again, it's not done under navigation right now, but it will be doable with future iterations of the robotic navigation platform. And this is just another example of how the robot will be able to play a role in every aspect of the procedure. So this increases its value and its impact on the spinal procedure. And this will allow more consistent surgeries and hopefully better outcomes. And this just shows you the post-op x-rays here. You can see no more spondylolisthesis with standing, and the instrumentation is adequately placed. And this was done with a robotic system, and it impacted every aspect of the procedure. Now, going forward, and this would be the next iteration. Again, technology continuously evolves, and I think it will be similar with the robotic system that in the future we'll see it being more seamlessly involved in every aspect. And this is an example of how it could be involved in a T-lift. And this is not currently available, but will be in the near future, is you could optimize cage planning. We want the T-lift cage to be midline. We want it a certain size. And right now, it's a little bit more guesswork. It is experience-based, but if you have a robotic planning station, I could plan the size of the cage I want to fit the anatomy. I could plan where it's going to be positioned optimally. Sometimes you may want it ipsilateral, but ideally just in a midline, which is not always easy to achieve currently. And here are the instruments, and this is just a cadaver showing what may be achievable. You can see how the robot now, the arm is used to hold the retractor in place in a certain position. And this retractor could be placed with the navigation capability of the robot as I showed previously, but it would be done more seamlessly when the software has been refined. And then a whole host of navigation capable instruments can be helpful with the discectomy component of the procedure. Again, this would optimize disc removal, cage placement, and hopefully we'll be able to allow a more consistent and reliable operation, which can happen these days, but it's a little bit more of a challenge. But this is the potential benefit of a robot being available and capable of impacting every aspect of the procedure. And this is just the cage placement. Now, you can see it's navigated utilizing a robotic navigation platform. You can see the cage going in exactly where you want it to. Which is not quite feasible yet as of yet, but I think will be in the near future. So I wanted to also talk about another example of the lateral lumbar nerve fusion, what can be done now with the robotic system, and what will be doable in the near future. Again, it's at an elementary stage in terms of the robotic platform and what it can do. Right now, the only role is screw placement, and its biggest impact is in single position surgery, where I think it is a market improvement over fluoroscopic-based screw placement in the lateral position. Here's just another example of a patient of mine. Again, similar to the patient before, has a spondylolisthesis and high-grade stenosis. And obviously could have used a MIS laminectomy and interbody fusion, as I showed in the previous example. But in this particular case, I elected to do a lateral approach for indirect decompression stabilization, which I think works very effectively in many cases, particularly with a slippage such as this. So what do I do now? Because I can't right now use a robot in every stage. So what I have been doing, again, to reduce radiation exposure, as well as I think make this a more reliable, consistent operation, is use navigation. So I use conventional navigation to place the lateral, to do the lateral lumbar interbody fusion. I follow that with single position placement of the pedicle screws utilizing the robotic system. And this is lateral positioning, pretty typical here. I use a Jackson flat table. And then once it's positioned, I use just conventional navigation right now. Again, no fluoroscopy. Here's a navigation frame. This tubular retractor was placed with navigation. We're not wearing lead here at all. Everything's done without fluoroscopy, unless there's some question, then obviously confirm with fluoroscopy. But this is the navigated pointer in the disc space, and the tubular retractor follows that. And here, since it's at L45, use a slightly oblique approach here to enter the disc space. And as you can see with the navigation pointer, it's easy to achieve this approach. And then here's a navigated trowel being inserted, and the cage will follow the trowel. So once the cage is inserted, this is where the robotic system comes into place. And this is very similar to what I showed with the MIS T-lift. This patient is lateral now. So I'm going to obtain intraoperative imaging data for the screw placement. So this is what's done to acquire the data. And once data is acquired and transferred to a robotic platform, again, the screw plans are made, and this patient is in a lateral position. And this is a placement of the screws, and you can see the robot aligns quite nicely for screw placement. And again, if you're using fluoroscopy, it's a little bit more of a challenge than the prone position, but with the robot, it's fairly straightforward. This is our chief resident putting the screws in. I'm cut off here. I'm off in the side because, with the robotic platform, it's very, very easy to do, and our residents can do it very, very easily in a straightforward manner. And the rod placement. And here, as you can see, the cage was in position nicely, and the screws were placed in a lateral position with the robot, and the outcome was very good. But what about the future? I think in the future, the robotic navigation platform, as I call it, will be involved in every aspect of the lateral procedure. And with this, it can minimize fluoroscopy usage. I think it would increase operative efficiency, particularly with multi-level operations. And it'll allow precise planning of the cage placement and optimization of the size of the cage. And I think this is very doable in the near future. It will require a certain advance in the software and instrumentation available for the robotic navigation platform. And it will also change the workflow. Previously, I showed cage placement first, followed by screw. In this iteration, it would be robotic assisted percutaneous screw placement, followed by the lateral lumbar interbody fusion, again, with the assistance of a robot. Again, this is not available now, but I think it will be in the near future. And this is just a cadaveric example of this. And again, you don't have to wear lead. This is cadavers in the lateral position. And the screw plans have been made, and this is just planning the skin incisions for screw placement. Here's the screws being inserted. Again, utilizing the robotic system for positioning of the arm to get the appropriate trajectory, drilling, then followed by the screws. So all 4 screws are placed in the lateral position. And then you could use the navigation capability of the robotic platform to plan your skin incision, which is what's being done here. So this would be your lateral skin incision. And this pointer, as you can see, projects the image, is demarcating the anterior border of the disc space. And once you have the borders of anterior and posteriorly, you could center a skin incision there. And then once the skin incision is placed, you can use navigation to insert your dilator. You can use a K-wire if you want. I would not do that, but this is all done with navigation without fluoroscopy. As you can see, there's no fluoroscope in view at all. And with sequential dilation, the robotic arm could be used to hold the retractor in the optimal position. And the pointer can be used to confirm adequate placement of the retractor overlying disc space. And this is an example of the discectomy being done here in the lateral position. Again, the screws have already been placed. Lateral position, the robotic arm holding the retractor in the ideal position. Now there's a host of navigation capable instrumentation, such as curettes, cobs, to allow the surgeon to do the procedure. And I would suggest using fluoroscopy if there's any question, but typically with navigation, it's fairly accurate. And then you could optimize cage positioning and sizing by using the navigation robotic navigation platform to plan your cage placement. And here's the size, the width of the cage, the length of the cage, and the angulation or the degree of lordosis. And once this is planned, you can insert the cage according to plan. And this is an example here. This is the cage holder, and it's putting the cage exactly where the planning was done. So in summary, I think spinal robots are currently assistive devices that are optimized for screw placement. However, spinal robots can be more than that. Spinal robots are built on navigation technology. So one can actually think about current robotic technology as a more advanced form of navigation in a way that combines a autonomous arm to allow accurate positioning. So I think of it more as a robotic navigation platform, and that's what I think future iterations will show, and it will impact every aspect of a spine procedure, including preoperative planning, retractor placement, decompression, cage placement. In the end, I think it will be helpful in producing a more consistent and reliable surgical procedure. It will decrease radiation exposure, and there's already evidence to show that. There's evidence that it improves accuracy. Operative efficiency, I think, will occur when it starts to impact every operation, and with future iterations of the technology to refine workflow. And hopefully it'll improve outcomes. I definitely think it has potential for that. That's about it. Thank you very much, and be happy to answer any questions.
Thank you very much for such a wonderful lecture, Dr. Park. I am sure all the audience has learned from your robust experience. Right now, we have a few questions from the public that I will read out loud to you. So, great. Which is the best robotic platform as per you at present, and why?
The best robotic platform? That's tough to say. I would say, you know, I do have I'm a consultant for Globus. I do have a relationship with Globus, which is one of the companies. So I just wanted to put that forward just as my conflict of interest. So that is the current robot that I am using presently. I think there are other robotic systems, and increasingly there are more robotic systems coming to the market. And so I have not used every system, so I can't comment on the best system, I would say. I can tell you that a robotic system that I'm currently using works fairly well. You know, it's like any new technology. It's like your iPhone, the first iteration of iPhone versus iPhone 11 or 12. It improves with every iteration. And I'm expecting a new iteration of the robot to come into play to allow more seamless navigation, which I think will impact the procedure. So I really can't comment on the quote best platform. I think there are a variety of good robots out there. I could tell you the one I use seems to work pretty well.
Okay, doctor, thank you. Next question, will robotic surgery for spinal cord injuries be a step to promote an improvement in neuroplasticity process?
So spinal cord injury and spinal robotics, I think are fairly disparate. You know, spinal cord injuries what we do now for treatment of spinal cord injury is we attempt to do something to prevent secondary injury. That's ischemia, inflammation, and there's various stem cell technology that's being evaluated. There are different inhibitors of these bad factors. Really, a robotic technology, I don't think plays a huge role in that circumstance. Now, it could play a role in the stabilization that occurs with unstable fractures, sure. I think it could play a role there in terms of placing the screws for fractures. And I've done that, in the thoracic spine. I've used a robot to place the screws, and it could be done percutaneously. From that perspective, I think there's a role. But in terms of treatment of the actual spinal cord injury itself, I don't think it plays much of a role.
Okay. In low-income countries, do you think this kind of technology will be available soon?
I don't think it'll be available soon. At least that's my impression. The problem is this technology is very expensive, and it requires not just a robotic technology, but other aspects of technology. Like the robotic system itself is fairly expensive. If you want to use intraoperative image acquisition, that's another expense to have an intraoperative cone beam CT scanner. And even if you don't, you want to use a preoperative CT, you need a specific registration frame for the fluoroscopic unit, and that's an expense. So it's highly expensive. So I think in the near term, I'm not sure it will be available in developing countries. I think in the future, as technology advances, it always becomes cheaper. So I think it's definitely something that will occur in the future. And in some ways it'd be better because early iterations of technology, it's expensive, it doesn't work. You have to get through all the bugs and problems with it until you get to a sort of a refined technology. And once that occurs, it gets cheaper, it becomes cheaper. And I think then it'll be more widely available.
Okay, Doc. Next question. How often do you have cerebrospinal fluid leak, and how do you resolve this problem?
Well, I'm not sure that has anything to do with the robot. For minimally invasive, like laminectomies or decompression, it does occur. And the treatment is very similar to what you would do with a traditional open approach. You attempt to get primary repair. That is doable with a minimally invasive surgery. It can be a bit more of a challenge. There's less dead space that is developed with a minimally invasive approach. So some surgeons will not even attempt to repair it. They'll put a little piece of gel foam and some fibrin glue and then remove the tubular retractor. And the patients tend to do well with that approach as well. But robotic technology has no real role with spinal fluid leaks per se. If you ask me, I think they do occur in treatment. I think it's been fairly well described.
Oh, of course. Dr. Jorge Torres from Colombia is asking, what is your opinion on using intraoperative image acquisition versus preoperative image acquisition?
So I've done both. I think both work. In our system, we have an intraoperative imaging acquisition unit. And so it's just, for me, it's easier to just obtain it with the patient position. I think it, in some sense, I feel like it's more accurate because I've already positioned the patient, then I acquire the image, rather than using a preoperative CT where the patient's just, say, supine. And if I prone them or put them lateral for the procedure, I'm always a little worried about that. But, having used both methods, they both work. So I don't have any data to support one or the other. I think they're both accurate. Now, in my own practice, obtaining a preoperative CT can be sometimes a little challenge. You need to get a high resolution CT. Sometimes our insurance companies want justification for that. So it's just easier for me. We have the technology. It's easy for me to obtain intraoperative image acquisition, but I think both work very well.
Okay. Next question. Do you think neurosurgeons will be unnecessary in the future for this kind of procedures, or there will be a space for them?
Oh, well, no, neurosurgeons are always going to be needed. It doesn't matter how much robotic technology advances, if you ask me, you're not going to have an independent, people are concerned about artificial intelligence. I think when it comes to surgery, there's definitely an art to surgery still. I think even utilizing robotic technology, even if it's highly refined, the surgeon still needs to see the patient, it needs to understand what's bothering the patient to develop a surgical plan. Now, the robotic technology will help you achieve an optimal surgical outcome, if you ask me, because sometimes when you have a surgical plan, it's hard to achieve every aspect of the surgical plan for a variety of reasons. I think with robotic technology, it'll allow you to achieve your surgical plan probably more reliably, consistently. But in the end, the surgeon is developing the plan, they're seeing the patient. There's a thought process involved. And so there is an art to medicine still. So I don't think neurosurgeons are not going away. I think we're going to be an important factor.
Yes, certainly, of course. Next question, how does robotics help in cases of adult degenerative scoliosis?
Well, it can be helpful. I think right now, personally, it's not refined to a point where I think it's seamless, where the trade-offs, because it does take a little longer if you're going to use it for a long segment case, makes as much sense. I think it's very helpful in terms of screw placement, obviously with deformities, with the rotational component, sometimes the pedicles are atretic. Having a robot help or assist with screw placement is a big benefit. Also with screw planning and preoperative planning that some robotic systems have in place or will have in place, you can optimize your correction. So I think it's a work in progress. Future iterations will actually have a bigger impact with deformity correction.
Okay. Mariana Agudelo is asking, and I quote, Dr. Park, thank you for your interesting and outstanding talk. Is there a difference regarding outcomes for patients between robotic surgery and conventional MIS?
Right now, I don't think there's any scientific data to support that. I think from my perspective, I think it is very helpful if you're more of an inexperienced surgeon for minimally invasive approaches, because the navigation capability, being able to, in a way visualize what's occurring better than what you can do now for MIS surgery will be very helpful in terms of the learning curve. So I think, I don't have any scientific data, but I think if you're new to minimally invasive surgery, utilizing some sort of navigation platform, and that's what a robot is essentially, can be very helpful in terms of preventing complications. Because when it comes to minimally invasive surgery where you can't see the whole anatomy, orientation, it can be a little bit of a challenge. And so we replace that with fluoroscopy, but fluoroscopy is two-dimensional. You don't see the anatomy quite as well using a fluoroscope. So having a robotic technology available, I think can be very helpful in preventing complication due to orientation.
Okay. This next question is very interesting, and is how do you teach residents to use the robot?
That's interesting. That's a good question, actually. We have a large residency program, and these days, residents gravitate toward technology, meaning they like technology. They're very enthusiastic about it. So, that's very helpful when in any sort of learning environment when trainees are interested in technology. I think learning to use a robot is not difficult. In fact, one would argue that you may lose something because you're not going through the process of thinking about what you're doing anatomically with your instrumentation, because a robot positions itself almost perfectly in place, and all you do is insert an instrument through the, like the effector to end effector of the robot. So you're not having to think about it so much. So in some ways, I think it can handicap a trainee if they don't go through the process of thinking about the anatomy. I'm going to put the instrument here, because the robot does it for you. So I think it's easy for a resident to learn how to use a robot, but if if all a resident does is learn how to operate with a robot, I think if they don't have a robot around, they're going to have trouble. So we try to do both. I think you need to train a resident to not use a robot and also use a robot. I think because it probably will be part of their future career. It's gonna. I don't think it's gonna go away. I think it'll be part of what they're gonna be using.
Yeah, of course, very important, these robotic topics nowadays. Next question, what applications does robotics have in pre-surgical planning of spinal deformity correction?
Well, so the current robot I'm using right now doesn't have much in preoperative planning. The Medtronic, I'm sorry for discussing companies. There are other systems that have, I think, a good pre-planning software where you could plan where the screws are going to be placed, and then depending on that, you could look at the software to plan how you want to contour the rods, for example, or how you want to adjust the screw placements to achieve better correction. So some of the pre-planning software, and again, I think it's elementary right now. The software will advance in terms of iteration and allow a surgeon to pre-plan how the screws are going to be placed and the types of osteotomies that will need to be done. So that is actually something that I think a fair number of companies are working with. So pre-planning, I think will play a pretty big role in the future. Right now, it's not quite. Some people use the word prime time, where it's there and it's easy to do. I think it still is a work in progress.
Okay, doctor, thank you. Next question, when using the Mazer robot, do you really need the O-arm too?
We don't have the Mazer robot personally, but you know, the Mazer robot and O-arm are from the same company, so it's a seamless integration. So I think I don't know if you have to use O-arm with the Mazer system. Most companies attempt not to do that because they understand that, you know, facilities may have different technology available. So, for example, I use the O-arm with my Globus robot. It's still doable. So they allow cross interaction. So I'm not sure you absolutely have to do that. But again, I'm not as familiar with the Mazer system.
Okay. Have you had any complications using robotic surgery?
The answer is yes. I think it's like with any technology or any technique, nothing is foolproof. So I have placed screws utilizing a robot that were not ideally placed. And for a variety of reasons, there's this skiving phenomenon. Sometimes when you're drilling through the guide, because of the density of the bone and the contour of the bone, the drill tip may slide. Even though the trajectory is appropriate, the bone is hard enough and it may be sloped where the drill slides a little bit laterally, so it doesn't enter the pedicle. So it could be misplaced in that regards. So, you know, I've had a few instances of that. So that's why, you know, I think I showed you the literature. It wasn't 100% accurate. It's like 90+%. So I think the robotic technology results in improved accuracy, but it's not 100% accurate, I would say.
Okay, we have an interesting question here. And has it ever happened that you lost a pedicle purchase, like a bad screw purchase or damaged pedicle? And if it did, what did you do to remedy this situation?
Well, that's a good question. I think if you're a spine surgeon who does a lot of spine surgery, you're always going to have a situation such as this where, you know, you attempt to cannulate the pedicle and for one reason or another, you injure the pedicle. Now, I have not had that occur with the robot yet. I've had misplaced screws, but I haven't ruined the pedicle. And so we could always salvage it. But, you know, I have had the experience of trying to cannulate a pedicle and ruin the pedicle. And there are a few options. If you are using navigation, you could attempt to put a cortical-based trajectory screw, for example, to salvage it. So that's more of like a pars insertion that attempts to attain more cortical purchase. So that's one option. You can put a vertebral body screw in. Again, like if you're doing this without navigation, it's a lot more of a challenge. If you have conventional navigation, though, you could see the anatomy three-dimensionally and then plan either a cortical-based screw or just a vertebral body screw, for example. And the most common way of treating that is, unfortunately, to go to an additional level for fixation. if the pedicle is no good.
Okay. What in lateral position for single stage LLIF information acquirement, how do you hold the reference array in place?
So the reference array for the patient reference, it just impacted into the posterior superior iliac spine or iliac wing. So just the bone of the ilium.
Okay. Does the robot automatically calibrate after or before every case?
No, the calibration is done with every case, right? Right at the beginning of the case. The instruments are calibrated, so it's done for every case. And sometimes, if we're concerned about the accuracy, we'll recalibrate.
Okay. Next question. Does the robot technology have a better impact in quality of life and return to work time than a traditional surgery? Could you tell us the numbers?
There's no good scientific data to support that as of yet. And some of it is because robotic technology is new. And robotic technology is often used in minimally invasive cases. So, and again, this is not wholly germane to spinal robotics specifically, but there's some data that minimally invasive procedures can lead to earlier return to work versus traditional surgery. But there's not good scientific data, so I don't want to say it does or not, because I don't have enough evidence to support that. Now I'm biased. I do a lot of minimally invasive surgery, so I do believe that it allows potentially earlier return to work. And as I said, robotic technology is geared to that. But I don't have enough evidence to say definitively that that's the case.
Okay. In US dollars, how much would a one level MIST leaf cost?
Are you talking about what our insurance companies will pay for a single level TLIF?
Yes.
That's different. The U.S. system is I think different than most countries. We have widely different reimbursement depending on whether it's Medicare, which is our government insurance plan, versus commercial, like a private insurer. The cost difference is many multiples. I honestly am not sure of the exact cost. I could guesstimate some numbers. It's only because I work in an academic center. I'm salaried. I don't really look at the billing specifically myself for our system, because I'm not in private practice where I do that. So I don't know the exact numbers. I could tell you that it can be expensive. I've heard of numbers of over $100,000, which is a huge amount of money for a single level minimally invasive, laminectomy and fusion. So some insurance companies are charged that amount of money. I can tell you, like our government payers do not pay as much, but it widely varies depending on the patient and what insurance companies they have.
Okay. Do you think that eventually the screw trajectory will be planned by AI software in an automatic fashion?
Yes. Yeah, absolutely. There's already certain scientific studies that have been published showing artificial intelligence can plan the screws very accurately. And I'm aware of several companies working on that. So I think in the near term, that's going to happen.
How many time do you spend to do a 1 and a 2 level TLIF?
Utilizing a robot. A 1 level TLIF at our center, again, we're a training program, so the residents are involved in the case. We'll probably take about 2.5 to 3 hours. And if you add a second level, it'll probably add a half an hour, 40 minutes to that.
Okay, wonderful. Do you think what are the limitations of robot procedures?
Limitations of robotic procedures. I think that depends on what you're asking limit-wise. I think right now, if you're doing long segment operations, I'm talking about more than 8 levels. I think robotic technology is maybe not worth it. Only in the sense that it'll increase operative time at that point, and you need imaging acquisition. You can only obtain with one intraoperative image acquisition about 4 levels of the spine. So you have to obtain multiple images. The screw planning, and then placement of screws can be a little bit of a challenge. It's definitely doable. I'm aware of surgeons that do it. So I think right now the limitations have more to do with the software is not quite as advanced in terms of screw planning. We just talked about automatic screw planning that would certainly make things easier. But robotic technology can be applied to most cases right now. So there's not any limitations per se in that regards. It's just a matter of your interest and how much you want to use the technology. It can be used for most procedures.
Okay. This is an interesting request. And can you discuss the learning curve for trainees?
For robotic technology?
Yes.
The learning curve is pretty steep. I think if you do about 5 or 6 cases, you'll be able to use a robot because it's designed in a way to make it fairly easy to understand and use. It is intuitive in many ways. There are a number of steps involved, and there's always nuances that need to be learned, but it doesn't take that many cases for screw placement. Because again, the robots are optimized for screw placement. So, I think it's just a simple 2-step process. The nuances are screw planning and positioning of how you're going to place a robot in the operation. So there are some nuances in terms of ergonomics, but usage of the robot, I think 5 to 10 cases, and you'll be able to use it at an adequate level.
Very well, thanks. What age cutoff do you use for pre-op DEXA? Does this impact your use of the robot?
Yeah, so preoperative DEXA, I use on any patient, or consider, I can't say I use on every patient over 65. Unless they have some history of osteoporosis or some sort of bone disease, and then maybe potentially earlier. Like if they've had a lot of fractures for whatever reason, and they're 55 or 60, I'll get a DEXA at that point. I'm sorry, what was the second part of the question?
The second part is, does this impact your use of the robot?
No, not really. I think, because a lot of times if the DEXA is poor, let's say their T-score is negative 3.5 or 4, like very badly osteoporotic, I'm going to question whether I'm going to do surgery or not. So that's the first question. Should we operate on the patient? If I am, a lot of times I'll start them on Prolia, which is a bone strengthening agent for tail. There's different names for it. And I'll do that preoperatively to strengthen their bones prior to surgery. So all robot does is it allows us to accurately place the screws. It doesn't make the decision about putting the screws, the bone quality or not. You can now use fenestrated pedicle screws for bone cement insertion, which I think increases the screw purchase. And so that's an option, and that could be done with the robot as well. It's a little fiddlesome, but it can be done.
Okay. Have you had any experience of pedicle screw inaccuracy by robot on your case?
Yes, I think that was a prior question, but yes, I've had some what's considered lateral skiving, and this is a pretty common or well-known complication. So the robot will position the drill perfectly in many cases, but the drill tip is not navigated and it could deflect off bone. The facet joint is sloped sometimes, and if the tip can slope, can skive off laterally, so you could have a laterally placed screw. So that can occur. That's why, I showed you the literature, the accuracy was over 90%, but it wasn't 100% because there are instances where, for one reason or another, the screw is not placed accurately. So, I'm not aware of any technology right now that makes, or technique that's 100% successful. So there is a bit of inaccuracy still.
This next question is very interesting. And how did you select a case for the robot?
I've been using it in most cases now. You know, sometimes if the patient is very obese, for example, I've had second thoughts about the robot only because the image acquisition can be a little bit of a challenge. But even in very obese people, BMI of 40, and yeah, I've used it. So I use it in most cases for minimally invasive TLIF now. I think if you're going to do the procedure, it can be used. So I don't necessarily have a rationale for not using it. You know, we've had some problems with using it. It's like technology. We've had a few software problems in the past where it hasn't been working, but that has to do with the software. It has nothing to do with my bias thinking I can't use it. So I think if you have a minimally invasive TLIF case, it can be used. So I think it more has to do with whether you're going to do the surgery or not.
Dr. Park, it is 10 a.m. right now, so we have different few questions right now. So if you're willing to answer them, we will have the time, and we will be open to do them.
Yeah, I have a few minutes. If I don't want to go over, but yeah, I'd be happy to answer them if you want me to.
Okay, doctor, thank you, and thank you for your time. So I quote the next one. Thank you for such an interesting and inspiring lecture. How is artificial intelligence going to impact the use of robotic in spine surgery? Many thanks.
Yeah, so it's a very good question. I think artificial intelligence is a very popular topic these days. And with our advancing technology, I think it will play a role in spine surgery. And there was a prior question on screw planning. I think that will be the first step. Artificial intelligence has already been shown. There's a couple of, I think, scientific articles showing this, where a machine can plan all the screw placements in a perfect position. So you don't have to be involved in that process. So that'll be the first step. The next step, if you think about it, is artificial intelligence will allow us to pick better patients. If we have a lot of data on what procedures are done and how patients do, and you look at all the variables, pain level, like comorbidities, the presenting problem, like say spondylolisthesis, the procedure done and outcomes, the robot, not the robot, but artificial intelligence may allow us to pick the best patients for a particular procedure, for example. And so I think it's going to play an increasing role in the future. It's just not going to be the immediate future. I think when it comes to a robot, like screw planning will be the first step.
Okay. Next question. Do you think that the costs for robotic spine surgery are going to be more available for the majority of users?
Oh, yes. In the future, yes. Technology always gets cheaper over time. It gets better and gets cheaper over time. So I think it will be more widely available. It's just right now, if you really think about robotic technology, it's in its infancy. So it's going to be very expensive at the beginning, and as it becomes refined and as technology matures, it'll be very, very, very inexpensive, or not very inexpensive, but it'll be less expensive.
Like more accessible for people.
Yes, yes.
Okay. Next question, and I quote, "Thank you for your presentation. Is there any way that the robotic is able to involve in bone drilling, such as laminotomy and facetectomy?"
That is a very good question. I think a lot of companies are working on that. That'll be another iteration, a future advancement of the robot. Right now, no. But that is an area of a lot of resources that companies are putting in. And that's going to be an important next step in the robot because that will allow the robot to be involved in the most, I think, sometimes most crucial aspects of the surgery is the bone drilling. And so I think that will be something the robot will be able to do in the future. It's just not now.
Perfect. What is the error margin for screw placement measured by millimeters?
Error margin? Well, navigation technology, and that's what the robot is based on, has an error rate, at least in this country, the FDA approval is between 1.5 to 2 millimeters.
Okay. And is it cost effective now compared to conventional screws placement?
I would say probably not. I haven't done the analysis, but the robot, at least in our institution, we paid quite a bit of money for it, and we could still put pedicle screws in without the robot. So when you talk about cost effectiveness, you have to look at the cost and the outcomes. And as I told you earlier, the outcomes, there's not enough proof that the outcomes are superior as of yet. So I haven't done the analysis myself, but I don't think it's cost effective quite yet. But that's true with most new technology, right? New technology is very expensive, and what it brings you, at least early on with the technology, probably is not as much as you're going to achieve later on when the technology is more mature. So again, I live in a country that allows that right now. So there's some expense involved with new technology, but as it matures, it'll become less expensive, and cost effectiveness always increases at that point.
Perfect. And we have the last question, Dr. Park, and the quote, "Thank you for your presentation. What is the cost effectiveness of robotic spine surgery?"
Well, it's very similar to the last question. I don't have data on that yet, and I don't think anyone does. I think as the technology matures, I do think cost effectiveness will improve. But right now, if I had to guess, it's probably not that cost effective.
Well, on behalf of CIEN, I'd like to thank you again, Dr. Park. This has been a wonderful lecture, and we are really grateful and honored for your participation in the 2020 IWBNC. You must know that more than 300 people were connected to your conference. So you are more than welcome to stay tuned to watch for more lectures from other speakers. In a few minutes, we will have Dr. Juan Uribe doing his lecture, The MIS Lateral Paradigm. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the agenda on our website, cienhus.com.
Thank you very much. This was wonderful. Thank you.
Thank you, doctor, and have a good day.
You too. Good day. Thanks again. I appreciate it.